Good afternoon, everyone. I'm Keel Muthigi. I'm a men's health specialist at Houston Methodist. I'd like to thank the SMSNA community for inviting me to give this talk. I'll be discussing fertility preservation strategies in male adolescents set to undergo cancer therapy. I have no disclosures pertaining to this talk. So I'll start with the introduction of the concept of what iatrogenic infertility is, and then go over fertility preservation options specifically in adolescents, barriers to fertility preservation, and future promising directions. So what is fertility preservation? This is freezing of embryos, eggs, ovarian tissue, sperm, or testicular tissue for future procreation. What is iatrogenic infertility? This is medically necessary treatments that impact fertility. There are several treatments that may impact fertility. This includes cancer therapy like chemotherapy, radiation, hormone therapy such as androgen deprivation therapy, certain surgeries in the brain and pelvis, and gonadotoxic agents. An example of this is certain biologics for autoimmune disorders such as lupus. Switching to cancer specifically now, here's some important statistics. Nearly 10% of all cancer patients are diagnosed between the age of 15 to 39. Keep in mind that this is primary reproductive years. About 12,000 adolescents are diagnosed yearly with cancer. 80% will achieve a long-term cure. So with recent advances in cancer therapies, patients are living longer, which is great news. Because of this, fertility potential is becoming more of a thought, where in the past it may have not been considered at all. And then up to 90% of cancer survivors experience fertility impairment as a result of cancer treatment. So what specific cancer treatments can have an impact? This could be an entire lecture on its own. I'm just going to briefly introduce this, but radiation is an example, especially testicular radiation or cranial radiation. Chemotherapy, specifically alkylating agents and platinum-based agents. These interfere with DNA replication, tend to have more of an effect on spermatogonial stem cells. And then certain surgeries, removal of one or both testicles, removal of the pituitary gland, non-nerve-sparing RPL&D. And now, options for fertility preservation. I'll touch on sperm banking, penile vibratory stimulation, electroejaculation, and testicular sperm retrieval. So what is sperm banking? This is cryopreservation of a freshly ejaculated semen specimen. This is cost-effective, it's easy, it can be performed in the outpatient setting. The key to remember here is optimal timing. This should be done prior to initiation of treatment. This is a very important concept. With certain agents, it can take up to 1 to 2 years to recover to pre-treatment levels. Some may not recover at all, so it's very important, if possible, to obtain samples before initiation of treatment. And then the goal is to preserve multiple vials. This may take multiple ejaculated specimens. This is a study published in JCO, examined oncologist attitudes and practices regarding sperm banking, found that only 50% introduced the topic or mentioned it to fewer than 1/4 of their male patients. This study also queried the actual patients aged 14 to 40 undergoing cancer treatment. Close to 50% desired to father children in the future. Only 50% reporting being given the opportunity to bank sperm, and only 25% ended up banking sperm. So this shows that there is work to be had here. What are some challenges specifically in the adolescent population? Younger patients may not have attempted self-stimulation or masturbation. This can be an awkward conversation between the provider, patient, and parents. There may not be access to an adequate facility. Keep in mind that these are adolescents who have not self-stimulated. We're asking them to give a sample in the clinic. This is, very anxiety-provoking. So this is something that we have to think about. This is where home kits can play a major role, where patients can provide samples in the comfort of their own home, as opposed to a scary environment in the clinic. And then we also have to keep in mind that there's certain cultures and religious beliefs that masturbation may be prohibited, ART may not be supported, so we have to take the whole patient and family into account. Next up is penile vibratory stimulation. This is a vibratory device placed on the ventral surface of the penis near the frenulum to elicit an ejaculation. This takes advantage of a reflex spinal arc, ejaculatory spinal arc. Afferents are stimulated by vibratory stimulation. Then we have efferents from the sympathetic and parasympathetic systems, leading to emission, and then projectile expulsion from somatic nerve fibers. This is a very nice option. There's devices available for both home and commercial use. Next up is electroejaculation. This is a rectal probe used to deliver a mild electric current to the prostate and seminal vesicles to stimulate an ejaculation. This again is taking advantage of the spinal ejaculatory reflex arc. With electroejaculation, we most know this technique for use in spinal cord patients with injuries T10 and below. However, it can be quite useful in this population as well. It's important to note that this requires general anesthesia. There's several different protocols for EEJ. If anyone's interested in this, I would advise you reach out to Dr. Imad Ibrahim. He's faculty at University of Miami, one of the world leading experts in this area. He runs a course every year on electroejaculation, so highly recommend. So this was a study out of Israel that looked at 45 adolescent cancer patients who underwent EEJ, and they found EEJ was successfully in obtaining sperm in about 2/3 of these patients. So it is a nice option to have. It does require special equipment, but for a program that wants to set this up, this is a very nice option. Last, we have sperm retrieval. This is obtaining sperm through testicular biopsy or percutaneous aspiration. This is very similar to conventional TESAs or TESIs we perform in the non-adolescent population. Now switching gears a little bit to barriers to fertility preservation. This is a study we just published last week, actually, where we examined certain barriers to fertility preservation. This includes lack of communication, which I discussed in a study earlier. Provider knowledge gaps. Oncologists may not know the impacts that these treatments are having on fertility, the concept of iatrogenic infertility. Limited resources and time. I've run into situations where a patient is admitted and needs to start chemotherapy the next day. How do we arrange and organize them to come to the andrology lab and give samples with less than a day before starting chemotherapy? These are all considerations. And then cost is something I'm going to touch on a little bit more here. This is data from the Alliance for FertilityPreservation.org, looking at cost for fertility preservation. So egg freezing is $10,000 to $15,000 per cycle. And storage costs $300 to $500 a year. Similarly, sperm banking $500 to $1,000 per ejaculated specimen. Storage costs $150 to $400 per year. This is a cost analysis study we did at the University of Miami last year. We were looking at men who were interested in sperm cryopreservation, about to initiate chemotherapy. Why did they not end up proceeding? 84% listed financial reasons. And then if we do a deeper dive with the cost analysis, it's not just the cryopreservation costs. There's potentially, based on insurance, consultation co-pays, infectious disease screening panels that are needed before freezing specimens. There's several costs. What we found is the total for a 5-year storage can be around $2,500. Many patients can't afford this. So what can we do as a field to address this? One thing is advocacy. I'd like to thank the AUA and the State Advocacy Committee for allowing myself and others to present this topic at the most recent advocacy summit in DC this past spring. There are currently 19 states that mandate fertility preservation coverage for patients undergoing cancer treatments. There are several states with both inactive and active legislation, and several states with no legislation at all. So this is really an area where we can make a difference as a field. Now I'm just going to touch quickly on future directions. So far I've discussed peripubertal and postpubertal patients. What about prepubertal patients? These are patients that haven't undergone puberty. They do not have mature sperm cells. It's important to note that this is experimental, purely investigational at this time. Most of the work is in animal models. But the central theme here is cryopreservation of testicular tissue. And the thought is this tissue has spermatogonium stem cells that can be matured at a later date after treatment. So certain options are future culture and autologous grafting of these stem cells, actually cultivating mature sperm in vitro, and then spermatogonial stem cell transplantation. This is very promising. Keep an eye out in the next 3 to 5 years. We're going to see some nice results from this. This is a proof of concept study out of Northwestern, Dr. Brannigan and his team. The children undergoing high-risk gonatotoxic treatments. They did testicular tissue cryopreservation in 23 patients. The average age was 10 years old. A majority of patients, 96%, had presence of germ cells on analysis. And the median time to start medical therapy was 7 days, so it's important to note that this didn't delay treatment, delay onset of chemotherapy or radiation. And then I want to end here with the concept of a fertility preservation program. This was really discussed nicely in the first talk that we had during this session. But this is really the gold standard where we're moving as a field. It involves coordination of several different things that's involved in fertility preservation. It's not just the oncologist, but infertility specialists, infrastructure like an andrology lab, coordinators, And there's also support staff that's needed, nurses, mental health specialists, social workers. This is really the future that we're moving towards. So in conclusion, all clinicians associated with cancer treatment should understand the concept of iatrogenic infertility. Infertility specialists are a critical component of cancer care in patients with fertility goals. There are several options for fertility preservation in the peripubertal and postpubertal adolescent population. Prepubertal is promising but experimental at this time. There are several barriers to fertility preservation, one of them being cost. A lot of patients just can't afford this. And then as a field, advocacy work is needed for fertility preservation, access, and coverage. This is where we can really make a difference. And with that, here's references, and thank you.